Thank you, Chairman. I will talk about the endovascular treatment of aneurysm, the role of coiling. This is my disclosure. This is my team. So in our department, we have 5 neurosurgeons for cerebral vascular surgery, and we have 4 members for the neurointervention. 2 belong to the neurosurgery, and the other 2 belong to radiology. So we are working together. And one of our members is dealing with the intensive care. So this is my team. So when you look at the current treatment of intracranial aneurysm, I think we have to see the aneural disease first. Sometimes the disease is very focal, only the aneurysm. Sometimes the disease is a little bit extensive or very extensive, so segmental or systemic. And there are various causes of aneurysm, so we have to look into that. And in the concept of treatment of aneurysm, we can consider exovascular treatment or endovascular treatment. And among endovascular treatment options, we have endosaccular treatment option and exosaccular treatment option. And we have the various devices for this treatment concept. So the flow of thinking should begin from the disease and then concept and to devices. We don't have to start from the devices. And let me share the one case. This patient seems to be in his 50s. Actually, he was found unconscious on the street. And at that time, the Glasgow Coma scale was E1, M2, V1. So Huntington score was grade 5. We took the CT. CT showed very extensive subarachnoid hemorrhage. So we immediately put EVD. The opening pressure was higher than 50 centimeter CSF. And the lab results showed very lower decrease in the GFR. So it was the pre-renal azotemia. So we gave him a lot of fluid. When we did the angiography, actually we couldn't find any causable lesion. So we took the 3D rotation angiography, and then 3D reconstruction image revealed those very small lesions in the between the superior and middle division of the right MCA. So when you look back the CT imaging, we thought this could be the causative lesion of this extensive subarachnoid bleed. So our decision was we recommend the surgery counterpart. Please consider the surgical exploration with preparation of the bypass and trapping, because it looked like a dissection, including all the parent artery as well. And maybe we can just clip if feasible. So this is the surgical finding. So we can see the thrombus, the aneurysm here is the same location. And the surgeon put the clip easily, and he reinforced the parent artery like this. So this was the surgery. This is the day 2 CT follow-up, show a good result, reduced the subarachnoid bleed, and the eGFR is being recovered. So we can compare the variant endovascular treatment option. In Korea, we have WEB, and we have various kinds of flow-diverting stents, and traditionally we have coils. So among those various devices, we can say coils are very versatile devices. We can apply coil for ruptured and unruptured aneurysm. The guiding principle should be the compact packing to reduce the delayed recurrence. So we have this 64-year-old lady presenting with multiple unruptured aneurysm. She had the basilar apex aneurysm here, and the bilateral pecom aneurysm is a kind of mirror aneurysm. So what we did was we placed a web and stent for the basilar apex aneurysm like this. So we can see the immediate control of the blood flow at the proximal part of the aneurysm. And we treated the pecom aneurysm with a coil using the double microcatheter technique. And we used the various kinds of coils, starting from Galaxy, Microplex, and Avenir Pico, like this. And on the other side, we also used the double microcatheter technique. And when we used, we actually mixed various kinds of coils, Axiom Frame, Hydrosoft, and Avenir Pico. So this is a 6 months follow-up angiography. We usually do the MR angiography for follow-up, but this patient was treated with a web in one location. So in this case, sometimes we do the DSA follow-up. So we can see the very stable occlusion of bilateral pecom aneurysm like this, and very stable occlusion of the basilar apex aneurysm as well. This elderly patient presented with unruptured superior cerebellar artery aneurysm. So our target should be the treatment of the aneurysm and save this branch. So what we did was actually we select the aneurysm with headway S with stem shaping, and we deploy the first coil, the first frame coil, the Optima Super Soft Complex 3x10. So we love to use the long coils as a frame coil, and with various attempts, we could make this frame. And we can see the branch is clearly saved with the frame coil. And then we introduced another microcatheter to give them more packing. So this was what we achieved at the end. So we additionally introduced 2x4, 1.2x4, 1.5x3, and we achieved this result. So we occlude the aneurysm and stay with the superior cerebral artery here. So this is 1.5 years after the treatment, and we still have very stable occlusion and very well preserved branches. So we use double microcatheter in this case. So for this, we need the very properly shaped microcatheter. So with this microcatheter, we can reselect aneurysm very easily, even without the microguide wire. And with this type of microcatheter, it's very easy to control the selection depth and specific location at the neck. Sometimes we want to locate the microcatheter tip at the proximal. Sometimes we want the distal location. And for the first coil basket, we usually use the long and complex or 3D coil. Rarely, very rarely, we use helical coil. And we have to control each coil loop for the first frame coil. And you can take your time. Sometimes the deployment rate is very important. So slow is better for the most of the time. And for the second microcatheter, second microcatheter is actually just a helping hand. And we could achieve the maximal filling packing density of 33% and achieve the delayed stable occlusion. So this is our technical variations in endovascular treatment using detachable coils. We can just use the single microcatheter, simple coil embolization. Sometimes we use the double microcatheter or more, triple as well. So until now, we've treated more than 9,000 aneurysm. So among them, we use the double microcatheter or the multiple microcatheter technique in more than 2,000 cases. And sometimes we use the microcatheter protection technique to protect the branch from the aneurysm, more than 500. Sometimes we have to use the coil for the branch protection. It's very, for very difficult cases, only 28. And sometimes we use the balloon remodeling, more than 700. And sometimes we use the stent assistance, more than 2,000. So sometimes we combine those techniques. Sometimes we have to use the coil even with, we use the flow adapting stent. Some aneurysm is very big, and some aneurysm has a very vulnerable part of the aneurysm, so we want to occlude that part with coil. So coil actually doesn't matter. There are so many kinds of coils in the market. So maybe no, in easy situation, we can use any kinds of coils. Non-torsus anatomy, easy microcatheter selection, moderate size aneurysm, very narrow neck aneurysm. Any coil does work very well. But yes, otherwise, when we encounter very difficult anatomy, including torsus access, difficult microcatheter selection, for example, twisted S, tiny aneurysm, distal aneurysm, wide neck. In these special cases, we really need good devices. Some aneurysms are very recurrence prone, so we need to take very special measures. So for difficult anatomy, coil delivery can be an issue. Coil detachment can be another issue. So we really need very good coil, coil shape and coil softness, and we need very good coil pusher, and we need very reliable detachment mechanism in this situation. For the recurrent prone aneurysm, we make a very utmost try to make the maximal volume packing. So we have to achieve dense packing. Sometimes we have to use hydrogel coil. And hemodynamic control should be considered in special situations, including the PCOM aneurysm and ACOM aneurysm. And sometimes we have to consider the healing mechanism. So sometimes we prefer Brady stent over the open cell stent. So this middle-aged lady presented with unruptured MC aneurysm, a very wide neck, and the globular part at the dome. And this patient, even though she is not so elderly, but the carotid is very ridiculous. So in those old times, we don't treat this aneurysm with endovascular. We just refer the patient for the surgery. But nowadays we have some good devices for access. So we can use offset for the guide of the Sophia plus intermediate catheter like this. And then we select the aneurysm. Actually, we start with SL10 90-degree pre-shape. But as you see, actually the plane of the aneurysm is a bit posterior. So we have to make this catheter to the right pigtail to stably select the aneurysm like this. So we have very complicated proximal, and the distal is also complex. So in that case, I want to use helical coil with very good characteristic of the coil pusher. So I opted to use Optima helical 2.5 by 6 as a first frame coil. And then we definitely need the stent to cover this wide neck area. So I'm going to, I place the second microcatheter for the stent placement. And now introduce a second coil, another helical coil. But the aneurysm, the microcatheter is starting to be kicked off. So I place the stent here. In this case, I place the Elvis Evo. We can appreciate the entire stent. And I continue to coil this aneurysm. Another helical coil, 1.5 by 4, and another helical coil, 1 by 2. So I complete the procedure like this, achieve the near complete occlusion of the aneurysm. So in this special case, I love to use Optima coil. Optima coil has one of best pusher. Why is that? It has a very specially made body coil, and it has a laser cut hypotube. So those features give the optimal pusher, provide very good balance among the implant, body coil, and spiral cord hypotube. So when you put the coil out of the sheath, other compared to the coil, we can see the coil part and pusher part separately. But when you look at the optimal coil, the distal pusher is almost like coil. It's very flexible. This is another case, the MC aneurysm with the daughter sac here. And I use the double microcatheter technique here. So I use the 2 microcatheters to fill the aneurysm. But during the treatment, we can see the protrusion of the coil loops into the inferior division of the MCA. So now I want to place a stent. And then I introduce more coils. So even though I used the optimal coil, I couldn't introduce the final part of the coil. So I just let them stay. It's actually jailed the outside of the stent. So this is the treatment result after treatment. And this patient has another small aneurysm in the MCA. So I select the aneurysm with a specially the shaped microcatheter. And I introduced optimal complex supersoft 1/3 here, a very good the basket. But when I introduce the second microcatheter and deploy the second coil 1/2, whole coil frame dismingled. So I have to begin from the start again. So now I introduce the first coil again, and then introduce the second coil. So now those 2 coils make a very stable coil mass. So I can finish the case like this. So in this special, the very small aneurysm, I love to use optimal coil as well. So we can compare all those kinds of coils in the market in Korea. So when you look at the microvention coil, hypersoft, when we calculate the relative stiffness, from 1 to 6, the same stiffness. But when you look at the Galaxy coil, from 1 to 3.5, the stiffness is 125. But when we use the 4 millimeter coil, it abruptly changed 167. So 3.5 millimeter coil, Galaxy coil, and 4 millimeter Galaxy coil is completely different in terms of physical characteristics. When you look at the optimal coil, from 1 to 2.5, the relative stiffness is 125, and the bigger coil is just slightly steeper. So no significant difference. So Exim prime coil is shows a very similar characteristics. So you can consider this kind of the relative stiffness when you choose the coil. And another thing is target coil. Target nano is 125. Target ultra is 150. So maybe you can start with the Galaxy coil 125, and then for the second coil, if you introduce the target ultra, maybe the coil frame disrupt very easily because the target ultra is steeper than the Galaxy in some situations. So we have to consider those characteristics. Now in the market we have a newcomers. So ID coil has a very low stiffness. And the target tetra has the same stiffness, but very different the coil loop action. And Avenue P coil shows a very low stiffness as well. So you can consider those new coil in some special situations. So optimal coil system provides they have when you look at the outer diameter, some coils 10, some coils 11, 11, 10, 11. So actually they adjust the outer diameter and primary wire diameter to make a very gentle shift of the coil stiffness. So you can see those numbers. They also provide optimal 18 coil as well for big aneurysms. So we have a 43-year-old lady with a very big basilar apex aneurysm. So what we did was, this patient has luckily very good PCOM from right side. So with some intraannular gymnastics, we could select the contralateral PCA. And we can place the horizontal stenting across the neck, and we select the aneurysm from the vertebra and basilar, and occlude the aneurysm like this with the Optima 18 coil. So this is the final result. Very compact packing from the frontal and lateral view. This is a 6-month follow-up, very stable result. So this is our snapshot. So sometimes we use the web flow disruptor, but most of the time we use coils for the aneurysm treatment. Very rarely we use flow diverter. So when you look at the procedure-related complication, thrombotic formation less than 1%, procedural annular rupture less than 1%. We have no procedure-related mortality. We have only 2 morbidity, 0.4%. Yeah, those kinds of complications. And when you look at the radiologic follow-up result, 6 months or longer, our follow-up rate is very high, almost perfect follow-up, and major recurrence occurred just in 2.5%. It's very low rate of recurrence. And this is final slide. So especially I want to mention about the pre-procedural antiplatelet medication. So we love to use low-dose prasugrel. So we completely replaced the clopidogrel with prasugrel in our practice. So we have some papers starting from 2016 and until the last year. In conclusion, COIL remains the most important and versatile device in endovascular treatment of aneurysm until now. And there are various coils in the market. So we should understand the basic characteristics of all the coils, and we have to select the most optimal coil in a given particular situation. And optimal coil system provides one of the best pusher and excellent clinical and anatomical outcomes. And please consider the short-term low-dose prasugrel regimen. Thank you for your attention.
Thank you very much.